But this uniquely actually holds the bone graft in place, so it makes for a very solid construct. And it's low profile, smooth, so it doesn't cause pain on the back of the head. That's a 3D reconstruction there. That's what it looks like in surgery. So this is a little bit confusing, but we saw good pain scores on almost post-operatively on almost every patient. At 1 year, the pain level, and these are patients we did about 6 years ago now, but pain levels came down from about 8.5 average to about 6. But now, for some reason, the patients seem to be getting quicker pain relief, and many of them leaving the hospital in 1 or 2 days, which is surprising. Looking at all these patients, we saw statistically significant improvement in phonophobia, sensitivity to noise, vertigo, dizziness, the headache and neck pain, syncope, that's fainting, pre-syncope, poor concentration, poor memory, double vision, photosensitivity, facial numbness, leg weakness, arm weakness, nausea, vomiting, incoordination, speech difficulty, and fatigue. So we saw significant improvements in all those. And on the right side, there's symptoms associated with a poorly functioning autonomic nervous system, dysautonomia. And we saw improvement in all those symptoms as well. Orthostatic grading scale, there's improvement in the orthostatic symptoms. Now, these symptoms weren't gone by 1 year, but they were substantially better. And with good physiotherapy and cardiovascular exercise, these symptoms tend to keep getting better. Many of these patients need Midodrine as well. But we saw a significant improvement in orthostatic symptoms, and on the right, the memory issues, thoughts, poor concentration, difficulty making decisions, slow thinking, foggy head, all of these symptoms improve significantly. This is a Konofsky score on the left. Blue is before surgery, and with an average around 50, these patients were very disabled. And after surgery, the Konofsky score improved to around 70. So the majority of patients returning to university had many get their PhDs, many go back to being taking care of their family or going back to school or work. Looking at whether patients would repeat the surgery, 96% said they would repeat the surgery. 3 said they would not repeat the surgery. But many patients, even after the surgery, had many issues with their comorbid conditions. And the average patient had 6 comorbid conditions. Some patients had over 20 comorbid conditions, and that's the full list of comorbidities that we saw. And so one of the reasons I like to see people at 3 months and even later is to help deal with all of these other comorbid conditions. My interest is not fusing the craniocervical junction, but getting people back to a real meaningful life. And that means dealing with all of these other issues. So there's no difference between those patients with low-lying cerebellar tonsils and CSF flow obstruction, for whom we performed a decompression, and the patients who didn't have those problems. They all did about the same. So the KI did not affect the outcomes. We had no intraoperative complications. We had 4 of the 53 patients who had a wound dehiscence, usually about a month after surgery, that had to get repaired, and 1 who may have had an infection, although the culture was negative. But we've made some changes now, and we've not had any wound dehiscences in the last 18 months. So what about loss of range of motion? And I've heard many surgeons express real dissatisfaction with the idea of fusing the skull to the spine because of loss of range of motion. But especially in the EDS population, range of motion is not an issue. This is a woman who's 1 month after her craniocervical surgery. And, she wanted to make the point that, she drove 100 miles in to see me at the 1 month appointment. And she said, range of motion is not an issue. But I have to say that after the surgery, I'm telling patients to try to keep their head straight, turn with their body more, and not wear out the rest of the spine by turning their neck too much. And by observing that simple rule of maintaining good posture and avoiding excessive movement of the neck, I think we've cut down the number of lower cervical surgeries by about 2/3. So we're talking then about adjacent segment degeneration, which is a big concern of people, that if you fuse the top, that you're more likely to wear out lower down. But I will say that right below the fusion of C2-3, it's exceptional. It's very rare that we ever see instability at that level. And if they follow that rule of posture, avoidance of unnecessary neck movement, avoiding looking at the cell phone, then the risk of needing more neck surgery is about 30% if they follow those rules. Thanks. Let's see. Okay, so what is causing all of these problems? And so here's a brainstem up a spinal cord in a neutral position. And with neck rotation, there's a great deal of torsion on the brainstem. So it should be, I think, intuitively obvious to you that if you twist the brainstem, you're going to cause problems. And we actually patented a mathematical predictive analysis of brainstem torsion and stretch, and correlated it very well with clinical findings. This was work 15, 20 years ago. And we proved to ourselves that mechanical deformity and stretch does correlate very well with neurological symptoms and outcomes. When we corrected the stretch, the pain and the deficits went away. And this has more recently been validated by other researchers. Well, when you twist and deform the brainstem, you also twist and deform these synthetic fibers here. And that, I think, contributes significantly to the overall dysautonomia. And I will mention that the autonomic nerve fibers speak to the mast cells throughout the body. And so when we when we improve the autonomic nervous function, a lot of the mast cell activity improves, but not always, but most of the time. It's also been shown if you stretch a nerve, you cause the myelin to disassociate, and you get clumping of the inner parts of the nerves and formation of these axon bulbs. And more illustratively, if you look at this rat optic nerve stretching 20% of its length, in 3 days it develops these axon retraction bulbs. It's the same thing we see with diffuse axonal injury in the brain following trauma. And if you stretch nerves, they can also allow this calcium influx into the cell, which can be deleterious. And stretching the nerves finally can trigger apoptosis, which is programmed cell death. Finally, the most obvious cause of many of these deficits is the decreased blood flow through the vertebral arteries. When you attenuate the artery from rotation, you can cause ischemia. And this is particularly evident when there's one artery much bigger than the other, or there's some anomaly of the circulation there. So in conclusion, the severe headache and neck pain symptoms of the cervical medullary syndrome, especially the weakness, lower cranial nerve dysfunction, and long tract findings, which are hyperreflexia and often other pathological reflexes. These things should prompt the consideration of craniocervical instability. And this diagnosis is facilitated by dynamic upright flexion extension imaging of the cervical spine. If necessary, you could get a CT scan lying down, but that's not nearly as accurate. You're not dealing with gravity. It's not a physiological position to be lying down flexion extension. And normally, if you have horrible instability in your neck and you're simply lying flat on the table, that spine can appear completely normal because you're not stressing the ligaments. You have to stress them to show the instability. The horizontal Harris measurement is very useful to assess potential instability at the craniocervical junction. And if the appropriate reduction, meaning alignment and fusion stabilization, occiput to C2, is associated with significant improvement of those neurological symptoms. And we still have some work in terms of refining the diagnosis of the population to operate upon and learning about the pathophysiology of what's happening, but especially the epidemiology, the natural history of what's happening to these patients who get surgery and who don't over the long term. So this is a boab tree. My brothers and I, in the Northern Territory of Australia, where we used to have a cattle station, don't anymore. And that is a tree. All right, thank you for your attention. Any questions? No.
So I'm a pediatric orthopedic provider, and I see quite a number of patients with generalized hypermobility, Ehlers-Danlos type syndromes, lung skeletal dysplasia. For the hypermobility patients, do you recommend certain standard screening at certain ages, starting to look for these things early?
Yeah. Well, I think, just to be clear, hypermobility is very common, but you're referring to hypermobility in EDS,
right,
so
so
the
I'm
higher
talking
level.
about the EDS population, genetically
And-
diagnosed, clinically
And-
pathologic problems with other joints.
And that's the most important question of the evening. And I think that if these patients were identified early and directed away from contact sports and injurious activities, then many of them would avoid some of the devastating things that happen later in adolescence. One, two, if they're diagnosed and the doctors like yourself understand what's going on, that validation is extremely important for their well-being. And I have so many patients who've been told by scores of doctors that there's nothing wrong with them. That is horrible. So physical fitness is really important. And so, but I think the right kind of activities that strengthen and avoid trauma. Thank you. Yes.
What are some of those activities?
Sorry.
What are some of those activities that someone can do, like tackling physical therapy?
Well, I'll let Dr. Pareto talk more about that because she's an expert. But I would avoid any contact sports. But you like horseback riding, and I think that's a great exercise as long as you don't fall off.
Sounds fair.
But I'll let Dr. Pareto put more meat on those bones. Yes. Yes.
Are there any studies looking at a group of people that have been fused versus not fused and long-term results more down the road?
Yeah, no.
No?
That's where I think the natural history was really helpful. But I can tell you, we've published, made a couple of, before this we had a 5-year study. And on the whole, I think those patients as a group are moving in the right direction. And some of them have really significant, terrible comorbid conditions that are slowing up that recovery. But even with successful surgery, it takes a long time for muscles to get strong again, for the ligaments and to be functioning correctly. And even the central nervous function has to be altered over time. It's the whole body needs to undergo a healing process. So you have to look in terms of 3 or 4 years for good recovery. But the study you talked about would be fantastic, and it hasn't been done yet. I certainly hope that the treated group are doing much better than the untreated group. And I'm pretty sure they are, yeah. Yes.
I saw you talk about a lot of the different measurements that are most relied upon for diagnosis, but the ADI was not really mentioned, Lancet dental interval. Is that not something that we should be
Yeah,
relying on?
actually, I did.
Oh, you did?
In the
I missed
acute injury, I showed a picture of it, the Atlanta dental interval, less,
I missed
yeah,
it.
7 millimeters being the threshold of representing unstable. But with Ehlers-Danlos syndrome, 98% of it is the alar ligament and other ligaments, not the transverse odontoid ligament, which is responsible for that big ADI, Atlanta dental interval.
Are there
So
any structures in that same area that can take the job of the ligaments that are injured? That maybe you could work on strengthening?
Well, I mean, they all contribute a little bit,
Right.
Yeah, I mean, there are a number of other ligaments that would contribute. If the transverse odontoid ligament is not functional, then the other ligaments won't be strong enough to hold it in place. So you have to have a functioning transverse odontoid ligament to keep the odontoid away from the spinal cord. Otherwise, maybe with a relatively minor trauma, the odontoid could tilt backward into the spinal cord and cause an injury. But your question, I suppose, is if you have a weak transverse ligament, but not ruptured, but just weak,
Well, it's
can
showing
the
bowing,
other
so
ligaments fill in enough to make
Right.
it strong enough? And the answer is that would seem reasonable, but and I'd say, yeah, in some cases that might work, yeah.
if it's showing bowing, is it just stretched or is it naturally lax? Or could something be pressing on it? How do you tell the difference if it's
Yeah.
lax
Well,
or?
yeah, if less than when the Atlanta dental interval is greater than 7 millimeters, then it's ruptured. If it's less than 7 millimeters, then it's probably weak and incompetent, but still present. And then in adult, you're allowed an Atlanta dental interval of 2.5 millimeters. In a child, 5 millimeters. But so 7 millimeters is the threshold.
Sorry, back to that question.
I have two for
What's
question. When did America or any other country start doing this type of surgery, the fusions? What's the recorded history of that?
Yeah, well, there's a guy back in the late 40s who was actually saying a lot of the things I'm saying tonight. And he showed that, when I got involved in this in the mid-90s, I looked at all the old literature, and that's where I got a lot of these measurements. So the measurements were there, but not everyone paid attention to them. So one of the things we've been doing with the Curious Syngomyelia Foundation is bringing all these measurements to everyone's attention, making them look at them again. Yeah, does that answer your question?
Yes. The second part of my question is, what is the normal protocol when you have a patient coming in that has almost, 80% of the different types of neurological, gastro, cardiovascular issues that we would chronically see with CCI and EDS, but they don't quite fit the criteria, they don't fit every single measurement to become a candidate for surgery? What is your typical next step with a patient like that?
We should.
You just let them know that they're totally screwed.
No, that's that's, I follow that. I mean, if they've got to meet, my criteria ultimately is, if this is my family member, would I operate on them, And so they've got to be, I've got to know that surgery would make them better before I would recommend surgery. And so I gave you some metrics and symptoms and findings and whatnot. And then you have to put it all together, and then you also have to think about, well, if this person is just getting worse and worse and worse, that's an important factor. But if they're pretty stable and they're suffering, but they're able to go to college and they're still getting, an A- average or something, but then you might just follow them. So there are no hard rules, you have to look at the big picture and the extended picture. So, and we actually don't shoot any of our patients. I want to be clear on that.
I'm guessing probably just go towards the idea of just treating the symptoms, right?
If we can treat many of some of the dysautonomic symptoms we can treat with drugs.
Right.
And then physical therapy, and mostly it's going to talk about the non-operative treatment. So, but you're right, there is that difficult in-between that we struggle with. I mean, it took me decades to get to the point of being reasonably confident in deciding we needed surgery, because there's no established pathway. I mean, we had to establish what metrics are sound and consistently valid. What are the symptoms and the findings that precede surgery and which get better after surgery. So it is kind of a difficult, these are difficult diagnoses to make, even though I made it look pretty simple, I think, right? Hopefully, yeah. It's a little more difficult than it might seem, yeah. So, does that answer your question?
Yes, thank you.
Okay. So, Masha, maybe we'll turn it over to the expert here for the.
It's pretty big shoes to fill right now.
Lincoln.
Thank you.
There. So anything I say now is pretty much going to be on the conservative care and hopefully come to somewhere close to what Dr. Henderson said. So let me just make sure I got this right. I have no idea where to press. All right, I figured that one out. Ah, there we go. That wasn't intentional. It's called intentional later when I left the house. So for those that don't know who I am, my name is Marcia Perino. I have been in the field as a doctor of physical therapy for 30 years now, and I have been blessed to be able to expand my knowledge and my career through different areas. I'm the owner and the founder of Active 5 Physiotherapy, but I'm also a patient. I am also an hypermobile Ehlers-Danlos patient. I have craniocervical instability with a stable subluxation of C1 and C2. I have mast cell activation syndrome, and I have POTS. I'm standing here right now, but I don't know if I'm gonna need to squat in a second. So just for those that get that joke about POTS will understand that. So the goal here is really to empower you guys to be able to, those that are trapped on that cycle of pain and disability. It's not easy to be there. And the goal here is literally change the way we see chronic illness, change the way that we actually treat patients with craniocervical instability, patients with hypermobile Ehlers-Danlos syndrome, patients that come with that everything presentation that we have a hard time presenting to our physicians. So let's talk a little bit and differentiate hypermobile Ehlers-Danlos syndrome from hypermobility spectrum disorders and even from Ehlers-Danlos syndromes. So hypermobility spectrum disorders, joint hypermobility, mostly without systemic involvement. That means that that patient might have maybe a little something, but most of it is just hypermobility to the joints, maybe a little gastric involvement, maybe something else. Ehlers-Danlos syndrome, now we are talking about a genetic connective tissue disorder that presents systemic involvement. So that patient will have problems with the stomach, with neuro, with cardiovascular, not always all of them, sometimes all of them. The key difference is really the systemic involvement. Do not confuse hypermobile Ehlers-Danlos syndrome with hypermobility spectrum disorders. They're two different things. Doesn't mean one is worse than the other, doesn't mean one patient feels better than the other. It just really means that they are two different things. Despite the known genetic mutations for hypermobile Ehlers-Danlos syndrome, there are subalterations on the collagen and this interaction with the extracellular matrix, components that will contribute to clinical manifestations. So just so you guys have an idea here, so we have our severity of systemic involvement and hypermobility spectrum. So a patient with a localized hypermobility or hypermobility spectrum disorder will have more of the mild, and this is not black and white, please don't take it that way. This is a spectrum. So they're gonna have a mild involvement. Someone already with peripheral hypermobility spectrum disorder will end up having more symptoms now. And then we end up getting into the generalized hypermobility spectrum disorders, which now this presentation is a little more significant. This patient presents with more pain, more disability, but is still functioning quite well. Now we fall into the hypermobile Ehlers-Danlos category. Those patients have more severe involvement. Those patients are going to have more systemic involvement as well. And then we come into the more, the other EDS subtypes, which those are more unusual to be found, doesn't mean we don't, but those patients are way more complicated than our other patients within the hypermobility spectrum. So a couple things I want you guys to understand, and I'm keeping this simple. Ehlers-Danlos is a, clumsy fingers, there we go. So it's a connective tissue disorder that involves the extracellular matrix proteins. So what do I need you guys to remember today? Abnormal extracellular matrix turnover, cellular changes associated with erratic signaling events leads to detrimental pro-inflammatory mechanisms, cause cellular dysfunction, more cellular damage, falls into a feedback loop where we have more degradative and inflammatory issues with the connective tissue, leading to a multisystemic clinical presentation of the hypermobile Ehlers-Danlos syndrome and also our EDS, HSD patients, hypermobility spectrum disorder. So just saying, you get stuck in a loop where there is tissue breakdown, cellular breakdown, and more inflammation, more cell breakdown, etc. So just a little bit for you guys to appreciate here is how different, so this is a control. This is a collagen fiber, and this is control. Look how different from the different types of EDS, how they look different from what's supposedly normal, okay? So how do we cause tissue adaptation? How do we strengthen someone? We impose progressive loading to these patients to strengthen the connective tissue. And then this adaptation will occur due to the consistent moderate stress over time. So you strengthen over time, you get that tissue stronger. What happens to EDS patients? We have an abnormal collagen synthesis. So what happens? If we load these patients, now we are breaking down tissue. Now we are causing, if we don't dose correctly, if we don't pay attention on how many, and each patient is different, by the way, right? So someone might take 6 repetitions, someone might take 10. Point is, if we push them too far, we break collagen. If we break collagen, we go back into that loop that we presented before, and we keep just going back and forth, and we don't get the patient better. That's the patient that goes to PT and say, I went to PT, they hurt me. I went to PT and I only got worse. So we need to be able to pay attention and dose correctly to minimize the tissue injury. So I just really wanted to show you guys from the tissue adaptation timeline, what is normal, right, to what is Ehlers-Danlos. So I think the biggest one that we have to look is the remodeling phase, which is normally 21 days to a year. It's twice as long, up to twice as long with a patient with Ehlers-Danlos syndrome. So when Dr. Henderson was talking about up to 4 years to recovery, there is a lot to obviously be recovered. We are looking at not only muscle or tendon or ligament, or in this case, we are looking also at ligaments, but we are actually looking at the whole body healing, right? So there's almost twice of the time in the remodeling phase. Now we keep breaking down the tissue of that patient if we keep pushing them, because they should be feeding a protocol instead of focusing on the connective tissue disorder, and we get them stuck over here. When they start going to remodeling phase, we break tissue down, we go back to acute, and they are already taking longer. Okay, so I just want you guys to remember that. So this is a little bit of an example of a hypermobile patient and how we see them so bendy, so limber. Even the postural control is actually lacking. Now we are comparing someone a little bit stiffer with someone that's hypermobile, and we can see how limber the fingers are, how much difficulty he has to touch his toes, and how easy for her it is to touch her toes. So this is what we are dealing with. I just want you guys to understand that we do not treat Ehlers-Danlos syndrome or hypermobile Ehlers-Danlos syndrome. We treat a person with a genetic trait that causes collagen, which is a protein, to be expressed erratically with an easier tissue breakdown that leads to all this diagnosis here. So I don't treat EDS, I treat patients with multiple diagnoses, including other systemic commonly affected, other systems commonly affected. So we are looking at autonomic disorders. We're looking at the cardiovascular system. We're looking at the gastrointestinal system, immune system, and the mast cell activation syndrome. And then we are looking at respiratory issues. Then we are looking at urogenital system, and endocrine, and cognitive and psychiatric. Who doesn't have at this point some sort of anxiety and depression, right? Because we get always told that we have a problem, we need a psychiatrist. I think after having so many systems involved, I think we are holding it pretty good together, right? So I just want you guys to remember really this. It is a multi-systemic diagnosis. But let's go dive into upper cervical and let's talk about a little bit. So Dr. Henderson already explained this part of the craniocervical instability, so I'm going to spare you guys from the repetition. I also want you to remember, to remind you a little bit about the craniocervical instability and the component of the, also the Chiari malformation, syringomelia, which you do see on those patients. This is syringomelia. It's a fluid-filled cyst sac we call syrinx, which can be present and can cause, we're going to look a little bit about symptoms as well, but in general, progressive weakness, loss of sensation, and even muscle atrophy. And this is how it looks like if you cut someone in half and you kind of look at it over there. Okay, so a couple red flags for the clinicians, but the patient should be aware too. This is quite important actually. So there are plenty neurological symptoms, autonomic symptoms. Chiari malformation has its own specific symptoms, and then the syringomelia. So I think the big one for syringomelia is this cake-like distribution of sensory loss. For the autonomic dysfunction, the tachycardia that is always confused with anxiety, right? The blood pressure fluctuations, the digestive issues, gastroparesis is huge, right? How many of us, or how many times as clinicians we hear that patient, I have 2 or 3 bites and I'm full. I just feel like I can't. Oh, here you go. I just can't. It has to happen with me too, of course. So how many times we hear those patients telling us, I took 3 or 4 bites and I can no longer eat. I need to, I feel full. So we have patients with neurological symptoms, there we go, presenting with dizziness, visual disturbances, tinnitus, dysphagia, difficulty speaking, swallowing, sensory changes. Okay, let's remember all that. Why this is important? Because if I understand my patient, if I understand all this presentation, I will be able to make a proper referral. And Dr. Henderson can vouch for this, many patients walk through the doors here at Actify and they do not have a diagnosis of any neurological impact. They have been told they have Ehlers-Danlos syndrome of some type, generally hypermobile, but they are complaining of headaches, dizziness, occipital pain, difficulty swallowing, sometimes even the clumsiness, the gait disturbances, but they have not had a diagnosis. No one has looked at their cervical spine. So we start that the referral, so these patients can actually receive the tests that we're gonna show quickly, and the importance for these tests for physical therapies as well. So a couple red flags we as physical therapists must recognize, as well as all clinicians should be recognizing all these red flags, because it will grant proper referral. Dizziness, vertigo, drop attacks, dysphagia, dysarthria, diplopia, nystagmus, ataxia, nausea, vomiting, all this and more should be taken into consideration, and a referral should be made. These are vertebrobasilar insufficiency symptoms. We need to make sure they get to a neurosurgeon, or at least get the tests initiated so they can be referred to a neurosurgeon. But why does it matter? Why in EDS is it important? We have ligamentous laxity because of that collagen deficiency, okay? So this ligament laxity will cause compression and stretching of the vertebral arteries as well. It will cause atlantoaxial instability, C1, C2. It will cause which will cause more blood flow compromise. Oops. It will also, we also have to take into consideration cervical positioning, because it may trigger ischemic symptoms, increasing the risk of stroke even. Compression of the medulla and brain stem from CCI, AEI, or Chiari can mimic and exacerbate the VBI-like symptoms. Okay, so I want you guys to keep that in mind. Why? Because we need to be able to refer this patient. We need to know that this patient is safe in our hands when we're rehabbing these patients. And that's why it is so important. What are the implications for physical therapy? We always need to screen for the VBI. We always need to know what we are going to do with these patients. If we're doing manual therapy, if we're doing traction, if we're doing exercises, involve head positioning, we need to know that this patient is going to be safe in our hands. We also need to monitor any changes of this patient's presentation when we are doing cervical flexion, extension, when we are doing rotation. If the symptoms are getting worse, we need to stop and reassess. When we reassess, does that mean this patient, do we know that this patient has craniocervical instability? Do we know which direction this patient is most unstable? Or this is a new symptom, and now this is granting a referral. That's why a multidisciplinary approach is so important. We do need neurologists, neurosurgeons, we do need vascular specialists to be involved in certain cases. So let's look at the physical exam and the diagnostic image results. Why is it important that we know? And I always stress so much, what is the direction? We were not trained, physical therapists are not trained to read the angles. I have trained myself on reading those angles, but we are not trained. And I think a lot of us don't even hear about hypermobile or Ehlers-Danlos syndromes in general as clinicians in the school. Maybe a paragraph, hopefully this will change. But why is it important that we actually educate ourselves and understand the physical exam and the diagnostic image results? So this is an example of a neuro exam, okay? We need to look into cranial nerve assessment when that patient comes in. We need to look at how are the eyes behaving during examination, motor function, swallowing and speech. Is that patient telling you that they are having now difficulty swallowing? Is this patient telling you that their voice has changed and they thought it was maybe even nothing important, but it is actually an important finding when it comes together in the context. Motor examination, look into muscle strength, any localized, any specific weakness that is not a weakness from not strengthening your muscles. Any muscle tone changes, is the patient spastic or maybe too hypotonic, cannot hold themselves up? Are their coordination off? Can they do the nose to finger task? Sensory evaluation, how is the light touch pinprick going? Are they numb around the neck? If you test them on the face, on the neck, if they're telling you there are changes, you're finding there are changes, this is actually granting a referral also to neurosurgery. Proprioception, assess the joint positions, change. A lot of those patients, you will tell them, I need you, I'm putting your arm here. Can you mimic, close your eyes and mimic with the other arm where your arm is in space? And they do this. And we ask, are you sure? And there's, yes, it's equal. And they are actually completely on level. So changes in position sense are critical. Also hands and feet. Reflex testing, mostly hyperreflexia, some hyporeflexia as well. Pathological reflexes, Hoffman's is probably, and Dr. Henderson can correct me if I'm wrong, but Hoffman's is probably the most common one over Babinski that we find in the clinic. It's a simple test to do. Every physical therapist learns in school. Gait and balance analysis, always should look into it. Is that patient unsteady, but it doesn't look, it's not because their knee is hurting or their foot is hurting? Are they having difficulty initiating that movement? Additional considerations is Valsalva maneuver. Are they telling you that they are getting symptoms when they cough or they strain themselves? Because that could suggest CSF obstruction. And then obviously the traditional palpation, put your hands on your patients, feel how their neck feels, feel the points that they report pain, feel if there is muscle spasm. Now muscle spasm is a tricky one, right? Because when you don't have deep stability, so we have the deep stability system, we have the global movers, and there are other divisions, we're not gonna go into details, but deep stability system holds you together. Global movers are your large muscles, quads, hamstrings, biceps. These muscles are to move you. Now, what happens when you don't have your deep stability system working? Because you're in pain. So if you're in pain, your deep stability system will turn off. If your deep stability system turns off, your superficial muscles kick in. Then they are in a spasm, right? Now you go ahead and you remove that muscle spasm. You just took the little bit of stability that patient just gained. So if you're gonna remove muscle spasm, if you're gonna massage, that's why a lot of EDS patients might say, I got a massage and I felt worse. I felt like I was discombobulated, because that was our stability. We took it away. We didn't activate the deep stability system. Now we lost the little bit of stability we had. So why is imaging important? Oh, and I want to make one more comment. So if you guys don't know this, we have the passive stability system and the active stability system. The passive are our ligaments, right? It's holding our bones all together, the capsule as well. And then the active are the muscles, right? Well, if our passive system is not working, our active system has to work double time, right? But there's then the deep stability system, which is your joint stability, and then there's the global mover. So just making that extra addition there. So why do we need to know the results of that MRI, the flexion extension MRI, and then rotational CT? Why is it important for physical therapy? It is important because it's going to guide our clinical decision making. It is important because we know the direction of that instability. And you don't need, as a physical therapist, you don't need to know how to read those tests. But you can talk to the neurosurgeon and they can tell you, listen, this patient is more unstable in a rotational pattern. So we know now to be more conservative when working rotation with that patient. The goal is to improve stability and prevent symptoms exacerbation. If we can actually get a patient in and a patient out of the session without making them worse, we already won. That's progress one, okay? Avoiding harmful movements, because if we have an anterior instability, limiting flexion to prevent brainstem compression is crucial. So we need to know that that patient is unstable in the anterior plane. If they have a rotational instability, we don't need, and Dr. Henderson mentioned that, we don't need to keep rotating them so far out. There is no point. They had a fusion. We don't want them rotating that far at all because we're going to cause more instability to these lower segments at that point. Multi-directional instability, we do need to implement a control load progression. So it is important to know in physical therapy, where is that instability? It's also important to understand when the patient has Chiari malformation and syringomelia and it's not a surgical patient, because we need to educate the patient that impact activities, contact activities might not be indicated for that case. So in that case, and addressing your question, Alan, in that case, horseback riding, for example, is a great activity to teach you to teach your postural muscles, to improve your strength, and has a whole psychological effect too. It feels great, right? But the risk of falling off the horse can make you think twice. Should I do this or not? It's not a contact activity, it's not a impact activity, but if you fall off the horse, it could be. So it's thinking about what are the pros and the cons of that activity. Definitely, I would tell you not to play beach volleyball or basketball or football, right? So those patients should be avoiding activities like such. And if they have syringomelia, just be mindful of any muscle weakness or progressive sensory deficits during therapy sessions. That means you have to refer the patient back to the surgeon, but always maintaining an open line of conversation. Why? Because that might be expected in that case, or that might be a red flag, and we won't know unless the expert will tell us. So again, what are the contraindications on patients with syringomelia and Chiari? If we don't know the patient has it, if we get that prescription that says, evaluate and treat neck pain, it's not a diagnosis, right? That's a symptom. So now I don't know my patient has Chiari malformation. I don't know my patient has syringomelia. And I make the choice, I never make that choice, I don't like traction, but let's go ahead and say that cervical traction was chosen. That patient has Chiari malformation. That can increase pressure at the craniovertebral junction. That can make that patient worse. So it is important that I know that that patient has Chiari malformation. Flexion-based exercises can exacerbate symptoms, so they're going to be contraindicated. Do I know my patient has the diagnosis? I will know what to do. I don't know the exact extent of the case. I might cause more harm than good. So just a little bit here, traction means all these things, right? Any of these presentations, and I didn't add there, but manual traction. When you go in physical therapy and they do manual traction, that is traction as well. It's not as powerful as that, but depending on the case, that could be an issue. So exercise strategies to be focused would definitely be low impact activities, like cycling, like walking, swimming. They're all going to give you cardiovascular health. They're going to improve other symptoms. They're going to be taking away the stress of the spine. Core and postural strengthening. There's a lot that we can do with patients that present with craniocervical instability, atlantoaxial instability, syringomelia, and Chiari, and any other pathologies of the upper cervical, or any pathologies of the spine in general, before we even get to impact or low impact activities. And then the conditional balance and coordination training, but always taking into consideration that we have to dose exercise correctly. We have to create a proper routine, take into consideration other coexistent diagnoses. Your patient has mast cell activation syndrome, exercise releases histamine. If that patient gets pushed a little too much in therapy, a little too much can mean very differently to each person. That patient has it has mast cell activation syndrome, you will end up causing a worsening of the case. The next day they're gonna say, I don't like therapy, I got worse. I had therapy, I got worse. Every time I go, I get pushed, I get more symptoms, I get fatigued. I am in bed for 2 or 3 days after therapy. We need to actually listen to all this. If they have dysautonomia, if they have POTS and mast cell, and now they have EDS, that takes a lot of management to be able to figure out what is the tolerance level of this patient. So imaging will guide my treatment decision, will prevent harm, will help me create a safer and a effective rehabilitation program for each patient. It will prevent me from utilizing any harmful techniques, not because the techniques are harmful, but it might be for that case That's why I need to be on task with each and every one. Know what works for one, doesn't work for another one. I can actually then optimize my exercise selection for each patient. And we're gonna go over a little bit on that in a second. And I can monitor then the neurological presentation, neurological symptoms. So let's just go over the comprehensive management. It goes beyond localized treatment, right? So you go to PT, you have neck pain, they give you neck exercises, and you go home. You walk in dragging the left leg, you walk out dragging the left leg, how you treated the neck, right? Because there was no prescription for the left leg. That cannot work for Ehlers-Danlos patients. We need to treat a whole person when it comes. I believe we should treat a whole person in any circumstance anyway. But for Ehlers-Danlos patients, we need to address the whole body. Collagen is present in the whole body and in every system of the body. Cervical instability is not an isolated issue. It will affect the entire neuromuscular system. And the traditional PT, unfortunately, because of the current model, will only focus on localized treatment. So if we want to make that EDS patient to really get better and have a long-term stability and function, we need to address them as a whole person. So essentially, we will work towards limiting excessive cervical movements and only prescribe what works for that person. And you might start where we don't even treat that neck. You come in with chronic cervical instability, AAI, Dr. Henderson said, this patient is not surgical. What can you do? I will start my treatment, but that patient is now in a lot of pain. So what am I gonna do? Can I touch their neck? Maybe not, right? Maybe I have to start indirectly. So I might have to start through the core, all right? I might have to start engaging transverse abdominal and banking on feet forward for neck stability. Global posture control, neuromuscular reeducation, address the autonomic nervous system as well through a vagus nerve modulation exercises, and overall functional movement restoration. What does that person need at this moment to function better at home? So a huge and very important thing to be mindful is the transversus abdominis and the pelvic floor. These patients present with pelvic floor dysfunction. And interesting enough, and it has a total implication on cranocervical instability and atlantoaxial instability. We did a little test and we found that we were using biofeedback, and we're putting the electrodes on the transverse abdominal and teaching this patient to relax the pelvic floor. And she kept complaining her neck was hurting every time. Every single time we tried to work with her. We decided to move the electrodes to the neck. What did we find? She couldn't turn on her transverse abdominal, but she was over-recruiting her neck to a point that she was leaving the session with significant brain fog. So what we started doing, we moved the electrodes from the abdomen to identify transverse abdominal activation, and we moved them to the neck to teach her not to use the neck. And we were able to get results, and we were actually quite successful. So that's something that we would like to study more, as a matter of fact. These patients normally come in with hypertonic pelvic floor because they, as a compensatory mechanism to counteract joint instability. So the hips are very mobile, the lower back is very mobile, and this ends up leading to pelvic pain and dysfunction. So we need to address them again as a whole person if we want to get good results for everything else. They have a tendency to overactivate superficial neck muscles. And if we do not re-educate muscle contraction, they end up being very muscular to the superficial layer and not being able to utilize the deep stability system. So how do we do this? Reactivation before stretching. Muscle re-education is crucial. Hypermobile patients usually lack neuromuscular control. We need to start with neuromuscular control. Focus on activation of the deep stabilizing system. If we stabilize them, the multifidus, the transverse abdominals, the abdominal, lower trapezius, we need to get those muscles working before we introduce dynamic movement. So if you're going to therapy and you're doing lunges, squats, you're not even able to activate your deep stabilizer system, you probably we're masters in compensating movement, right? We make it look good too. Clinicians really think we're doing right. We are not. We're treating everyone around in the room. We are actually utilizing compensatory mechanisms, and that's how we end up hurting so much next day. If we only strengthen, do only strength training without stability training, we're reinforcing dysfunctional movement patterns. Okay, so let's first establish neuromuscular control. Multi-range isometrics too, because if you're doing only your isometrics in neutral, literature shows that we only, depending on the muscle, the range of motion for that muscle, you only increase strength by 5 to 15 degrees in each direction of that isometrics done. So you need to work on multi-range. You need to go through the range of motion that is safe for that patient as well. And then we gradually progress to functional strengthening only when we do notice they have enough stability, only when they can actually maintain the joints in the right position and able to perform the movement that we are requesting. This way, and this way we are going to be able to reduce pain, improve function. This is going to improve patient outcomes. It takes longer though, because remember when we go back on that tissue adaptation there, on that tissue remodeling phase, we take longer. So we are not going to be the patients that are going to respond with 12 sessions over a month. We actually more likely to respond over 12 sessions over 3 months, coming in once a week, doing your work at home. So you can actually slowly build, and I don't like to call it strength anymore. I rather call tissue resilience. It's more about resilience of that tissue than it is about strength initially. We address the root causes. So if we actually focus on neuromuscular control, on autonomic function, on postural stability, we're actually addressing the root cause of these problems. And then, of course, working as a team with the right physicians. And we will be able to get a much better result. And obviously, patients are such an important part of the plan of care. You guys are so great as patients because you all verbalize and you're so knowledgeable about about your conditions. And it took that because we need to advocate for ourselves, right? So I encourage conversations. I encourage that you come to the office and say, listen, we did this last visit. I think that was a little bit too much. Can we dial down? Can we not do this movement today? Can we find a different position for this exercise? And it's so important that we have these conversations and listen to the patients as well. So why does traditional PT usually fails for EDS patients with upper cervical instability? Because it prioritizes the strengthening of global muscles before stabilizing the deep stability system. Because it over-recruits superficial muscles, okay? And usually it involves some form of passive stretching, okay? And it neglects the neuromuscular control and the proprioception. It overlooked autonomic dysfunction. We all know that patients present with POTS and mast cell activation syndrome. We need to take that into consideration, okay? And we need to adapt the treatment to accommodate any flares of those systems. It does also fail to integrate a full body approach. We unfortunately just go because of it. This is about more of a system than it is a specific to the profession. We don't have the time in clinic in a traditional setting to address a whole body. It isolates cervical stabilization only without addressing most of the time, due to lack of time and structures, scapulothoracic core and pelvic stability. So what are the strategies? Prioritize closed chain exercise and pseudo closed chain exercise. What is that? Closed chain, your hand or your foot or your body part is in contact with a stable surface that is non-moving. That's the most stable form that gives us proprioceptive feedback. So now we know where we are in space. So the closed chain, now we are using a band, a bungee, cables. Those will give you a little more challenge and will give you now, still giving you the feedback that you need. They're still going to give you the proprioceptive feedback that you need, but it will be a little more challenging now. It will enhance cervical joint stability or any joint stability for the sake of it. We now emphasize eccentric control. So concentric contraction, eccentric contraction. Eccentric contraction away from the hypermobile direction will regulate the pattern. So now you will have better control. Multi-angle isometric training for cervical spine and any joints. It will improve your ability to find yourself in space. So what is the evidence-based treatment? Modify load application for mechanical advantage. So a lot of us have a hard time doing anything that's too long. Straight leg raises, side lifts, arms with the arms straight. Bend them. You shorten the lever, you gave mechanical advantage. You gave mechanical advantage. Now this patient is going to be able to perform better. Okay? Utilize ground reaction forces to enhance proprioception. Everyone knows what ground force reactions are, right? It's the force that the floor exerts on the body part as the body part is pressing down, let's say. So ground force reaction is not really on the ground. If I'm pressing here, this wall is pressing back at me. So I need to learn to use that to my favor, and I use that to the favor of my patient. So it gives sensorimotor feedback, postural stability, and helps then in global muscle activation later on, facilitating improved cervical coordination. Understanding the complexities of EDS and CCI as a multi-system disorder requiring an integrative approach is essential. Instability affects the neuromuscular control, the proprioception, the autonomic function, and the biomechanics. We need to do assessment and image-driven interventions, recognizing red flags, correlating imaging findings with the presentation of the patient. And then the target rehabilitation strategies that I just mentioned, right? Let's start with closed chain, move on to a little more open but yet closed chain. Eccentric over concentric together as clinicians. It's not like this our patient, and we all collaborate because we can make that person better, right? Early intervention with conservative care can help delay or avoid surgical interventions like foot fusion. We want that patient to be strong enough if they have to go to surgery. So a pre-op strengthening phase or resilience training, like I prefer to call it, is crucial. I think it's just not just about managing symptoms. It's about really restoring the stability, the movement, and the long-term functions, giving them their life back. Okay? Let's always move beyond the limitations and into possibilities for these cases. Healing from EDS, CCI, and chronic illness isn't just about symptom management. It's about restoring function, giving these patients their life back. 12 years ago, I was in a wheelchair. 12 years ago, I was told I was going to be disabled, and that was it. I didn't know I had hypermobile Ehlers-Danlos syndrome. I didn't know the tachycardia that I was experiencing wasn't anxiety, but actually POTS. I didn't know that I wasn't able to eat and feel full or felt full immediately because I had gastroparesis. I was thinking it was just me, and it was in my head, and I wasn't trying hard enough. It's beyond that. We're not broken. Patients with EDS are not broken. Healing is possible. It takes time. Healing is different for each one of us. What my goal for my life might be very different from someone else. But whatever it is, we want to deliver to that person. If their goal is to walk their dog, to walk their child down to school, that's their goal. We have to work towards that goal and deliver them the life that they're looking for. We work together as physical therapists, as clinicians, as specialists, psychologists, psychiatrists. We need a bit of everything in our corners. But eventually, healing comes for whatever shape and form it is for each one of us, depending on the diagnosis and the complexities each one of us have. But it's always about possibilities. Thank you.
I have another one for Dr. Henderson.
Yes.
With pain being so subjective, I've noticed that a lot of them had like before and after numbers and stuff, and one of them had like a level 7 to meet a guide you towards diagnosis. I was wondering if you have a standardized pain scale that you use.
Yeah. It's the visual analog pain scale 1 to 10. 10 is the most severe pain. 7 is quite, 10 is the worst pain you can imagine. 7 is severe pain. And that scale has been very useful for determining which patients are in the category of needing surgery. That's your question. It's the visual analog pain scale.
Okay.
Anyone?
There's one question for Dr. Henderson on here, online. It's if you have Eagle syndrome with jugular and internal artery compression and CCI, which surgery would you do first?
Right.
If you have.
Yeah, no. Yeah, I think there's a neurosurgical doctrine that you start at the top and work down. And so, generally speaking, you treat the craniocervical instability first. The Eagle syndrome is actually a bit of a misnomer. It was originally an ENT diagnosis that had to do with painful swallowing dysphagia. And we've changed that term to mean compression of the jugular by the calcified stellar hyoid ligament. The problem with that is that even if you have severe stenosis of the jugular vein, much of that venous blood may have already found collateral channels to leave the brain and go down into the body. So we don't know which of those jugular stenoses are pertinent and need treatment. In general, if you clearly have craniocervical instability, that's something that clearly needs to be fixed. So I would take care of the more obvious, important things first. And the stellar hyoid compression of the jugular is very complex, can be subtle, and we're not really clear yet on which patients will benefit long-term from those treatments.
Yes, no more questions there? Oh,
So I'm curious with physical therapy training. So because you're obviously compelled and compassionate about this whole area, but when you have physical therapists around the country with your slip, I'm sure that looks very different. And is there any training or move to try and get physical therapists more educated about a better way to treat Ehlers-Danlos?
so I will be honest, I was not trained in any of this. I trained myself. I watched lectures, read, went after studies. I think what we are missing, and I still don't think we are emphasizing enough the importance of not only connective tissue disorders, but connective tissue disorders and the repercussion on the craniocervical area or the upper cervical spine in general. So I think we need to push for some sort of education or inclusion on curriculum for this type of presentation, for this type of diagnosis. So these patients can now go to therapy and the physical therapist really knows what they're talking about. Some of them are gonna have been exposed to it already, but in general, the majority, in my understanding so far, this is not part of the treatment.
Thank you.
We're all good? All right. Dr. Henderson, thank you for flying all the way from Maryland here. Appreciate your presence. So thank you all online for being here with us tonight, and you all have a great night. Thank you.
I'm gonna go call it a stop. We're supposed to be at a water.
You're doing that twice. I had my phone. Yeah, I had my phone.
Claire Shannon,
Yeah.
I actually worked at Johns Hopkins. Yes. But you're kind of the neighbor. But actually, putting it into small world, my whole family is
Whatever, right?
younger.
All right, that's-
Yeah.